Hi, good evening. Thank you very much for joining us to talk about reforms in death certification in England and Wales. My name is Gerard Ross. I'm one of the medical legal advisors, and you'll have seen me do a few of these webinars with you before. I'm very lucky tonight to be joined by Dr Suzy Lishman, who's a consultant histopathologist in Peterborough and the president of the Association of Clinical Pathologists. Dr Lishman has been heavily involved in drawing up the medical examiner guidance and similar, putting together the system. So when I was writing a talk on this to give for a webinar, I thought it might be good to actually involve somebody who did it as a big part of their job. So hence, Dr. Lishman has turned up and gracefully agreed to share her wisdom with us. There's a question box you can see in front of you on this new ON24 system. You can drop some questions to us and I will try and collate them, and I'll put them to Dr. Lishman at the end of her presentation. If anything burning comes up in the meantime that I need to interject and ask Dr. Lishman, I will do so, but hopefully I'll let Dr. Lishman get on and give her talk. Dr. Lishman, welcome, and thank you very much for coming.
Thank you. Thanks very much for inviting me. So, as you've heard, I'm Suzy Lishman. I'm going to talk to you about death certification reform, and I just thought I'd give you a bit of my background to this and how I got involved in it. So, as Gerard mentioned, I'm a histopathologist by background, but I was also involved in the Royal College of Pathologists. I did 12 years as an officer, culminating in president from 2014 to 17, and it was really through that role that I got involved in medical examiner implementation, because the Royal College of Pathologists is the lead college for medical examiners. Through that, I started working with the Department of Health. They have a strategic programme board that oversees all of the death certification reforms, of which medical examiners are just one part. And so I've been working with the Department of Health since they set up that board in 2016, and we still meet monthly. We met this morning to see through these reforms with all of the other stakeholders, including Welsh Government, the Coroner's Society, the Chief Coroner, the General Registrar Office, Office for National Statistics, Ministry of Justice, and so on. I'm also training lead for medical examiners, so I've been responsible for helping to develop e-learning modules, which are available on e-learning for healthcare. Anybody can do them. So if you're interested and want to do some CPD, there are some medical examiner modules on there, but also delivering face-to-face training, which pre-pandemic was always in person at the college. Since then, we now offer an option of either online or in person, and the online one works remarkably well with breakout rooms, small discussions, and then plenary sessions. So we've trained about 2,700 medical examiners, all senior doctors, so we have enough workforce for all the medical examiners that we need in England and Wales. Looking at my other things I do, I was lead medical examiner for my trust, North West Anglia, and set up the medical examiner service there in 2019 and was lead medical examiner for 5 years before handing it over last year. I also chaired the Medical Examiners Committee at the Royal College of Pathologists for 5 years, which is the committee there that oversees setting the standards, agreeing the training and everything else. I'm independent mortality advisor for Spire Healthcare. It's a slightly random thing that came about because when the medical examiner system was first rolled out in a non-statutory phase from 2019, it wasn't involving private hospitals at all. The idea was that they would come on board much later. But Spire heard about the early adoption in the NHS and they wanted to get involved early on. They thought it'd be really valuable. They don't have many deaths. Obviously, as you know, as a private provider, they typically do relatively low risk elective surgery, but they do have a small number of deaths and they wanted somebody independent to look into those. And so I do that for all of their 35 hospitals. I also am on the working group for the National Medical Examiners Good Practice Series, and I'll come on to those a little later, but there's a really fantastic series of documents that look at particular areas that medical examiners might have difficulty with or not be familiar with. So we just published the 18th of these this morning on inherited cardiac conditions. We also have them on things like eating disorders, urgent release of the body, sepsis, antimicrobial resistance, dementia, and things like that, child deaths, all the really challenging things that we need to try and stay up to date with. And each of those has got guidance, links to the current guidance. I'm co-editor and author of part of the medical examiner textbook, the only one that there is, which was written for the pre-September non-statutory scheme. So we're in the process of updating that for the new system. And I have been a crematorium medical referee for nearly 20 years. And this combination of being a post-mortem pathologist, so being familiar with death investigation from that aspect and working closely with the coroner and formulating causes of death, being involved in medical examiners and being a medical examiner and setting up a service, and then being a crematorium medical referee and working from that is fairly unique and has been very helpful in enabling me to sort of link up all the different aspects of these reforms. So I'm going to talk to you about a little bit about the previous system, just because it's the one that many of you will be more familiar with, perhaps it's what you were taught when you were training. Then something about the new legislation that's come in, and then I'll focus on the new system. What's changed? What do we have to do now? Particularly the role of medical examiners, who they are, why they're there, what they do, and then changes to death certificates, registration, the role of the coroner, and to cremation forms. I'll let you know how to find out more, and I know that Cam has put some helpful links in the resources section, so that any of the documents that I refer to, you'll be able to find a link to and have a look for them for yourself. And I'm very happy to take questions at the end, but also in the middle if Jared finds that there are some, if there's anything I keep saying that you don't understand, or I've missed something, or I've slipped into jargon, do let me know, and I'll try to correct that. So I thought I'd put in a glossary. I'll try my best not to use jargon, but it's very difficult. This has been my life for about the last 15 years, and certainly I've been living and breathing it for the last year or two as we've approached the statutory system. So I do quite easily slip back into this. So just to be really clear what I'm talking about, ME is a medical examiner. That's a doctor who reviews deaths. MEO is a medical examiner officer. That's not a doctor. MEOs can come from a range of different backgrounds, such as nursing, radiographers, paramedics, coroner's officers. It's a new, like medical examiner, the medical examiner officer role is a new one. So we have people from a wide range of backgrounds and have got quite a steep learning curve over the last few years, getting up to speed with what that job involves. MCCD is the Medical Certificate of Cause of Death. That's the sort of paper checkbook that you fill in, and we often refer to it as the death certificate, just for shorthand. But that's what I mean by that. RCPath is the Royal College of Pathologists. Department of Health and Social Care is DHSC. MOJ, Ministry of Justice. GRO, General Register Office. And the reason that's important is part of the reason there have been delays, and this has been delayed over the years, is because it's three different government departments are having to work together, and they've got their own ministers, their own secretaries of state, their own regulations, and everything has to try to align. So it's not as simple as the Department of Health sitting down and saying, right, this is what we want to do. It doesn't affect anybody else, and we'll just get on with it, because it's all interconnected and has knock-on effects on other government departments' regulations. And then AP is the attending practitioner, and that's a doctor who attended the deceased during their last illness. And that's
Can I ask a question on that point, Suzy?
Yes,
somebody's just popped up in the chat saying a question I was slightly confused about, but do we have a unified definition of the attending practitioner in the legislation? I guess this must be, various people could be the attending practitioner at any one point.
So that's a really sensible question. And the answer is no. There is no legal definition of attending, and it is not mentioned in the legislation. They just talk about the attending doctor. There is work going on, and I'm setting up a working group to try to put out some pragmatic guidance on what we should be thinking about in terms of what attending means. I'll come on in a minute to some of the changes in what counts as having attended in terms of the time before death. But in terms of whether you actually attended or not, I think the most sensible thing to think about is, did you make a meaningful contribution to the care of the patient while knowing about their history, and did you document it? So if you get a phone call in the middle of the night and it's a completely abstract question about, is it okay to give paracetamol with aspirin? And you say yes, that I think wouldn't count as caring for the patient. But if somebody calls you while you're on call, or you see a patient on a ward round and there's a clinical question that you're involved in answering, and you make a record of the fact that you have done so, then I think that counts. Now, previously, there was this whole thing about, did you see them in person? Did you see them on video? Did you see them on telephone? Was it a telephone call?
Yeah.
Which was particularly for cremation forms. And the rule then was it had to be either in person or by video, and that just speaking to somebody on the phone didn't count as having attended them. I think it's a slightly more blurred distinction than that. So, for example, an intensive care consultant who's working on call from home over the weekend, who has multiple inputs into the care of a patient, and is making all the decisions while talking to junior members of the team, other healthcare professionals. I think it would be reasonable for them to say that they had attended that patient, even though they hadn't seen them. So I'm not suggesting that you all go away and start saying, yes, I attended because I had a phone call. And it's really about making a meaningful difference to the management and making decisions as you go along. I am hoping to get some guidance out. It will be nothing more than guidance, partly because I'm writing it and I have no statutory power to do, but there is no legal definition of attending, is the short answer that I've just given you a very long answer to.
Thank you very much.
And the really interesting thing about this one is we get it argued in both directions. We have doctors that we approach to write the certificate and they say, oh, no, I never attended them. And you go, well, you did see them 5 times last week or something. And they go, yeah, but I didn't. Doesn't count as attending. And then you have somebody else who says, well, I never actually saw them, but I spoke to their neighbour on the phone 5 years ago, and I think that counts. So you've got people who are both trying to argue that they did attend and people trying to argue that they didn't attend, which makes it really difficult to write anything. But I think, use judgment, I think, is the only thing I can say at the moment. So the previous system, the medical certificate of cause of death, was written by the attending practitioner, as you know. And that attending practitioner, who has to be a doctor, there is no change in the legislation at all. It's always had to be a doctor, and it still is, must have attended during the last illness. And again, there was judgment involved in saying when did the last illness start? If somebody dies of old age, it obviously didn't start quite very recently, but was it 2 years, 3 years, 5 years? And you also had to have seen the deceased either within the last 28 days or after death. And it had to be one or the other, didn't have to be both. The medical examiner service was in a non-statutory phase, so it was not mandatory for all deaths to be reviewed. And so different areas had different numbers of deaths that were being reviewed at that time. The Registrar of Births and Deaths would review the cause of death written on the medical certificate and decide whether or not it was acceptable. If they thought it was not acceptable, they would refer it to the coroner. And it's interesting, the doctors who write the certificate didn't even always know that happened. So they might say, well, I've been writing renal failure for years. Well, they might have been, but it's probably been bounced to the coroner for years as well, because it didn't go back to the original doctor to say you can't have renal failure as a cause of death, you need an underlying cause. So in the old system, typically coroner referrals were done by either the attending practitioner or the medical examiner or the registrar. There was an increasing problem with something called uncertified deaths, which you may not be familiar with. This is where the cause of death is known, but there is no doctor who's available to write the certificate. And of course, that would go to the coroner in the old system, and sometimes the coroner would investigate and sometimes they wouldn't. But essentially, that person would not get a death certificate with the cause of death written on it. It was not possible, apart from during the pandemic when there were some easements to the law, it was not possible for somebody who didn't attend to write a certificate. And so that meant that even where the cause of death was known, And then perhaps the doctor had gone on holiday or left the practice or was off sick or something, and there was no way of contacting them. But the records were really clear. But they were the only doctor. These deaths had to be uncertified. And there were increasing numbers as we came up towards the end of the non-statutory system. There was always a 5-day target for registration, and the onus for registering the death was on the family. And legally, they had to register within 5 days of death. And they could be fined if they didn't do that. Thankfully, this was not something that was ever enforced, because actually quite a lot of death certificates take longer than 5 days to be issued, particularly over its calendar days. So over a bank holiday, at Easter, for example, there's not a chance that you'll get a death registered within 5 days, because 4 of them are days when the registrar's closed. But that was the law, was that the family had to register the death within 5 days of death. And up until September, there was cremation form 4 for anyone who's been cremated, and between 70 and 80% of people in this country are cremated, so it is the majority. And that would be the attending doctor who would fill in the form and provide all the necessary information. Cremation form 5, which was the confirmatory certificate, went during the pandemic and never came back. So in the non-statutory system, medical examiners have been around for quite a long time. There were pilot schemes in 2008, and they were written up and lots of lessons were learned from them. But the scheme as we know it now was introduced in 2019, and all trusts in England and health boards in Wales were encouraged to introduce a medical examiner system to start reviewing deaths. And the plan was that they would start reviewing hospital deaths first, because that was a bit easier. And so for the last 2 or 3 years, 100% of deaths in hospitals in England have been reviewed by a medical examiner. And then from 2022, once we reached 100% of hospital deaths, medical examiner services were encouraged to start reviewing community deaths, whether that was people who died at home, in a hospice, in a mental health trust, in a care home, wherever it happened to be. And the uptake of that was variable around the country. Some GPs embraced it, and there were some areas where 100% of deaths were being reviewed by medical examiners a year ago. Others thought, they were too busy, and this was one more thing that they just didn't have time to do, not unreasonably. And so they decided that they weren't going to get involved with the medical examiner system until they had to. But by September, when the statutory system came in, over 80% of all deaths, so that's 100% of hospital deaths and 60% of community deaths, were being reviewed by a medical examiner. And this was always the intention, that there wouldn't be a huge step in September when it became statutory, but it would be a relatively small jump, just taking on board those last few practices that hadn't previously engaged. And over 1 million deaths had been scrutinised by medical examiners before it became statutory. So the 9th of September 2024 was go live date. That's the date on which all these reforms came into place and medical examiners had to review deaths. So since then, every death in England and Wales must be reviewed by either a medical examiner or a coroner. And often it's both, but it has to be at least one or the other. There is no way to register a death without their involvement. And just a reminder, it is England and Wales only. Scotland and Northern Ireland have different systems of death review. So it's only England and Wales. So the primary legislation to put medical examiners on a statutory footing was first included in the Coroners and Justice Act of 2009. And in that act, medical examiners were going to be employed by local authorities. So they were going to, because they're independent of the NHS care being provided, the idea was they'd sit in local authorities, and that's where they would go. It became clear with the pilots, and once we tried the non-statutory system, that was not going to work. Local authorities didn't want to take on the employment of 2,500 doctors with all the complications that go along with that, terms and conditions of employment, pensions and everything else. And doctors didn't particularly want to give up NHS employment to go and work for local authorities. And it just wasn't a practical solution. So a decision was made to employ doctors within the NHS, medical examiners within the NHS, and that change was incorporated in the Health and Care Act of 2022. So these are the two main bits of primary legislation that say medical examiners must review deaths and that they will be employed within the NHS. But primary legislation doesn't give very much detail. The detail is in the regulations, the secondary legislation. And this has been worked on since 2009, essentially, getting all the background regulations in place. And so the Department of Health and Social Care had 3 regulations that it needed to lay. The first was about the role of the National Medical Examiner. So it had to give statutory power to an individual who was appointed to the role of National Medical Examiner, providing leadership across the system. The second was changes to the Medical Certificate of Cause of Death. And so the Department of Health and Social Care has taken responsibility for the medical certificate over from the General Registrar Office, and it needed to make changes to the certificate, and so that needed legislation to do so. And finally, it was the medical examiners regulations, which mean that medical examiners have to be appointed and employed within the NHS to review deaths. So these are the 3 bits that the Department of Health and Social Care were responsible for, and these were laid in April 2024. And that's when the clock really started ticking. We knew once these had been laid that we were moving towards actual implementation after several years of delays. The Ministry of Justice also had to lay some regulations because there are implications for coroners and for cremations and for attending practitioners who are completing cremation forms and referring deaths to the coroner. And so there were some tweaks to the notification of death regulations, which are the rules that were laid in 2019 that determine when a death must go to a coroner. And they were laid in May 2024. So that was the next step. So that was really helpful. And then the final piece of the jigsaw were the changes for the General Registrar Office, because there's no point having a new medical certificate of cause of death if registrars aren't legally allowed to accept it and register the death. And those were laid about 3 days before this went live. So we will go right up to the wire, waiting for the changes to the Births and Deaths Registration Act. But they did get through the week before the 9th of September. And so everything aligned, ready for it to go live. So hopefully by now you'll have come across medical examiners, but just to explain who they are, what they are senior doctors. They must be at least 5 years post-qualification, but typically they are hospital consultants and GPs. There are a few associate specialists and other grades, but they're mostly consultants and GPs. They are independent as far as they can be, given that they're employed within the NHS, which was really the only solution to make it happen. So they're independent of the care of the deceased that they're looking into. So you would never review the death of somebody that was cared for by you or your team. So you mustn't know the patient. And they are part-time. This is a job that people do in addition to their normal clinical role. So typically, medical examiners will work 1 or possibly 2 sessions a week as a medical examiner, and then the rest of the time they'll be doing something else. As I mentioned, the Royal College of Pathologists is responsible for the training, and medical examiners must by law now undergo that training to work as MEs. And they, as I say, they review every non-coronial death in England and Wales, and some coronial deaths as well. They are appointed and employed by acute trusts in England, and it's NHS Wales Shared Services Partnership in Wales. So Wales has a slightly different model. So in England, they're based in each hospital, and in Wales, they have a single medical examiner service for the entire country. So they actually sit outside health boards, and they review all deaths in the country. Made much easier by having a single electronic patient record for the whole country. So 2 slightly different models. And it's really important to understand that any medical examiner reviews any death. Medical examiners are essentially a specialty in their own right. So you're not a pediatric medical examiner or a surgical medical examiner or anything like that. any medical examiner has to be able to and is trained to review any death. There was some concern initially that there would be a charge to families for medical examiner certificates, such as there used to be for cremation forms. But during the pandemic, the Department of Health started to fund medical examiners, and then a decision was made at the end of the pandemic that they would continue to do so. And so it's entirely centrally funded, and there's no charge to families, which is great. This is one of the things that we and many patient groups all lobbied for. We work very closely with medical examiner officers. We couldn't do it without them, as so many of us do work with other members of the team. But medical examiner officers really provide the continuity within the service because they're typically full-time and medical examiners are not. And we have to provide weekend and bank holiday cover. It's not a 24/7 service, but all medical examiner offices have to have some provision for urgent release of bodies, particularly for faith communities. So why do we
just before we go into why there, one question has come in, I think from somebody potentially looking to be a medical examiner, asking whether a retired GP could become one. I'm assuming they need to maintain their license to practice.
Yeah, so you have to have a license to practice. It can be the only thing you do if you want. And there are some people who've retired from their clinical role and continued as a medical examiner. We initially said that you must be within 3 years of retirement to be appointed as a medical examiner, and we've extended that now to 5. So yes, you can work as a medical examiner after retirement, as long as you retain your license to practice. Thank you. So why do we need medical examiners? You know, when somebody dies, there's so many other things that are looking at death. You know, we've got the death certificate, we've had cremation forms, there's the coroner who's reviewing unnatural deaths. We all have our appraisal to make sure we're doing things properly. There are initiatives like PSERF. There are SJRs, structured judgment reviews, as part of learning from deaths. There's NCPOD doing national audits, the CQC looking at trusts. There's so many different ways in which care is reviewed. Why do we need medical examiners? Well, the short answer is Harold Shipman. The recommendation to set up a national system of medical examiners came from Dame Janet Smith's inquiry, and it was one of the strongest recommendations that she made. So the Shipman inquiry, and then it's also been mentioned in other inquiries, Robert Francis's Mid-Staffs report, Bill Kirkup and Morecambe Bay, and so on. All of these where there's been some sort of scandal that hasn't been discovered until late, where there have been deaths involved, have said, introduce medical examiners. They would hopefully have stopped this from happening, or at least picked it up a little sooner than they did. But calls for death certification reform are not new. Death certificates were first introduced in 1836, and it was recognised really quite quickly that they weren't fit for purpose. And in 1893, there was a Parliamentary Select Committee report that recommended death certification reform. And there have been numerous reports over the years, and that reform has only just come into place in September last year. So it's taken a long time. I haven't worked on it quite from the beginning, but certainly for many years. So the benefits of the medical examiner system are intended to be independent scrutiny of all deaths. So somebody who wasn't responsible for the care of the person while they were alive, scrutinising the death to see if there's anything that can be learnt. The idea then being that there's greater transparency for families and reassurance, and safeguards can be put in place if necessary. For the first time, there is equal scrutiny for burials and cremations, because until September, if somebody was being buried, there was no review. There's no burial form equivalent of a cremation form. So it was only people being cremated that had that extra review. And now everybody who dies, irrespective of whether they're being buried or cremated. It provides bereaved families with opportunities to ask questions and raise concerns. And they really value having that chance, particularly if somebody dies in hospital. They don't always get the answers that they would like. They may not even see another doctor after the death of a loved one. So medical examiners provide that opportunity to ask questions, and if they have concerns, to escalate them. A big aim is to improve the quality and accuracy of the medical certificate of cause of death. And this, I think, is going to take some time. we all sort of learned sort of by osmosis, I think, how to write death certificates. There's a bit of teaching, perhaps at induction at some point, but really it's a little bit of asking colleagues, and does this sound reasonable? And I think there's been a bit of slippage in the understanding of how to formulate a cause of death and what are not acceptable causes that can go on a certificate. And as I say, because the registrar used to just send any unsatisfactory causes straight to the coroner, the person writing the certificate didn't even know that what they'd written wasn't acceptable. And so they may have been writing it for years, but they may have been going off to the coroner. So one of the aims is to improve the quality. And of course, if you're only writing 1 or 2 of these certificates a year, then it's difficult to get really good at them. But medical examiners are seeing 10 or 20 of these a day. So they should be experts on causes of death. And by improving that, hopefully the knock-on effect is improving mortality data, so that the information that's collected nationally about causes of death will be more accurate. And that will then feed into things like health policy and decisions about where to spend money, because we'll know the cause of death. Also ensure appropriate coroner referral. So we've always known that some deaths that get sent to the coroner didn't really need to go. And, about 20% didn't need to go to the coroner. Similarly, there are a number of deaths that really did need to go to the coroner previously, but didn't go. Somebody wrote a natural sounding cause of death and it didn't. So medical examiners, one of their areas of expertise is understanding the legal framework and when deaths have to go to the coroner. So they're very well placed to advise on that. And then, of course, as I mentioned, they'll feed into governance pathways locally and regionally to support learning and improve care. This is absolutely not about blame in any way. This is just about making care better for patients. This is probably the most important slide of all of mine that explains what medical examiners do. And they're aiming to answer 3 questions. Firstly, what did the person die from? So that's both reviewing the record to find out, what actually happened to them, but also making sure once you've identified that it's written down properly in the right order, that everything that needs to be on the certificate is there with underlying causes and things like that. So getting the cause of death right. Secondly, does it need to go to the coroner? Once you've established the cause of death, is there anything in that cause of death that suggests that it may be unnatural or the coroner needs to know about it? And then are there any clinical governance concerns? Is there anything to be learned from this death that we can feed back in to improve future care? And medical examiners do this via 3 mandatory steps. A proportionate review of the medical record, wherever that may be held, GP records, hospital, paramedic records, and so on. Interaction with the attending doctor. And in hospital, that's often a quick phone call, or the doctor will pop down to the bereavement office. In the community, it's often just an email from the GP saying, this is what happened and this is what I think the cause of death is. So it doesn't have to be a meeting or a face-to-face or a phone call even. It can just be an email if it's straightforward. And then finally, really importantly, interaction with the family, at which we'll explain to them, this is what's on the certificate, and explain what the conditions mean. Ask if they have any questions about that. Then ask if they have any other questions about the care of their loved one. And finally, whether they have any concerns. And families often say, well, I didn't want to make a fuss, or I don't want to complain. Everyone was so fantastic. I didn't really want to mention it. But you get some really helpful intelligence back from families when you just ask, is there anything we could have done better? So I mentioned that there was legislation to bring in a national medical examiner. So we've had a national medical examiner for several years. It's currently Dr. Alan Fletcher, who's an emergency physician in Sheffield, and he was involved in the pilot schemes from 2008. So he's a very experienced medical examiner. He sits within the NHS England National Patient Safety Team, and he provides the professional and strategic leadership for medical examiners across England and Wales. So setting quality standards, I noticed one of the questions early on, trying to standardise the way in which medical examiners approach their work. And he has a very collaborative approach, which is essential, working with coroners, registrars, faith communities, patient groups, and so on. He issues a regular bulletin, and the National Medical Examiner guidance, both for setting up and running a service, and also those good practice series that I mentioned, looking at particular areas of care that may need a little more scrutiny, and then issues an annual report. And the National Medical Examiner has appointed 7 regional medical examiners that cover England, and there is 1 medical examiner for Wales lead. And then there are also corresponding medical examiner officers, so 7 lead MEOs in England and 1 lead for Wales, and they work together and meeting regularly as a team, and I'm a member of that group, again trying to standardise the way in which this is rolled out across the country. So I'm going to talk now about changes to the medical certificate of cause of death that came into place on September the 9th. And there are 5 main changes to the certificate itself. It looks pretty much like it used to, but I'll go through in detail each of those 5 changes. So it is a new paper document, so you have to completely get rid of the old ones and destroy those, and this has replaced them. And there's a new certificate called the Medical Examiner Medical Certificate of Cause of Death, which didn't previously exist, which I'll tell you about in a minute. So this is what the attending practitioner MCCD looks like, and that's what it's been called, the AP MCCD, we call it. And so the changes are, the first one is in the cause of death, previously it used to be 1 A, B, C for the conditions leading to death, and then 2 for significant conditions that contributed to death but didn't directly cause it. And a 1D has been added, so it's now 1 A, B, C, D. You don't have to fill all 4, but this just brings it in line with international standards. So there was no other reason than that, really. But I often use it rather than having to double up on a line. You often find that there's quite a series of events that lead to death. That's quite handy. Then there is a new box about was the deceased pregnant within the year prior to their death? And for most cases, that's really obvious and you can answer it. And this is just to try to identify particularly those deaths that are not related to pregnancy. So we are always very good as doctors at identifying deaths relating to childbirth, pregnancy, or the perinatal period, for example. But if somebody dies 9 months after having given birth, often it's not thought about. And so it's just to try to focus people's minds on that. So within a year of death. So that's now on the certificate. On the back of the certificate, there is a whole section about ethnicity. And I'm going to point here. Yeah. So if the patient has declared their ethnicity and it's been recorded, then you can indicate it on the certificate. There is no suggestion that you have to go looking for it by asking family members. You don't have to guess or decide for yourself. But if there's a self-declared ethnicity, then it should go on. The reason for this is, you may remember during the pandemic, it became apparent fairly early on that different ethnic groups were affected differently by the coronavirus and had higher rates of death. And nobody knew why that was. Was it their occupations? Was it inherently their ethnicity? But nobody was recording it. There was no official record of the ethnicity of people who died during the pandemic. And so it was recognised that in order to be able to support groups that are particularly at risk, it will be helpful to record that information. Faith groups would like to include faith as well as ethnicity, but that is not what has happened in this certificate. So it's just ethnicity as self-declared by the patient, but you don't have to ask anyone if you don't know. You can say don't know. Not known is an option. Another really important one is the presence of implantable medical devices. And although it doesn't say so here, it does say in the guidance, we're asking about hazardous implants here. It's things like pacemakers, radioactive seeds and things for prostate cancer, anything that could harm either the crematorium staff or the crematorium itself, the building, by exploding or causing damage. This is the question that used to be on the cremation form because it only applied to people who are cremated. But since we've got rid of cremation forms, it needs to go somewhere, and this is where it's gone. So this is really important. Don't know isn't an option intentionally, because basically if you say, I don't know, then that person can't be cremated. And given that the majority of people are cremated, that would be a shame to say, right, if I don't know, you can't be cremated. So it's very important to record if there is anything, and if so, if it's been removed. And then, as usual, the attending doctor signs it, but the new bit is a box at the bottom. The medical examiner has to sign the certificate as well. And they're essentially saying that they agree with the cause of death. They agree, having looked at the patient record, they agree with the formulation of the cause of death. And that's why you may find, if you propose a cause of death, the medical examiner may come back to you and say, have you considered formulating it this way? Or do you think this might explain it better? Because they're now putting their name to the cause of death that's been recorded.
Again, I don't want to interrupt your flow, but I'm going to.
Right.
We're getting a lot of questions. I mean, there's nearly 70 questions already. Questions about disagreements between doctors and the medical examiners, which is something that we talked about when we first talked about doing this webinar. Can you talk about how disagreements might be addressed? Yeah.
I mean, the first and most obvious is just to talk to each other and explain to each other why you disagree and what you think's happened. And, sometimes the attending doctor knows more about the deceased person than the medical examiner does. And the medical examiner only has the record to go from. And it may be they've got the wrong end of the stick, or something that happened wasn't recorded. Or often what you find is it's difficult to see nuance in the record. And things that appear to be of equal importance are not. And so one condition was very, very important and dominant in somebody's health, and others were very minor. But it's often difficult to see that when you've just got a list of the conditions that somebody had. So the attending doctor is obviously best placed to talk about that. And so they could just explain, yes, I know they had rheumatoid arthritis, but it was under control. It didn't cause them any problems, and I don't think it contributed. And that's fine. It may be that the medical examiner is trying to explain that certain causes of death need qualification. So you can't just put aspiration pneumonia, for example. It's not an acceptable cause of death on its own. You can't just put upper GI bleed or intracranial hemorrhage. None of these are acceptable causes of death on their own. They have to have a qualifier, such as spontaneous or the underlying reason for it. So it may be that they're just trying to suggest that there's a better way of wording it. Often we find people use 1A, B, C just as a list. So 1A, heart disease, 1B, pneumonia, 1C, cancer. And they're just writing a list of conditions that the person had. And so the medical examiner could go back and explain that's not actually how the 1A, B, C thing works. It's about a condition that leads to another, that leads to another.
Fundamentally, if there's a major disagreement and they cannot agree, I take it that you would go to the coroner and say, we disagree, we can't manage this.
Essentially, the cause of death is not established if nobody can agree on it, and it would go to the coroner to decide. We would work really, really hard to avoid that happening. And I encourage medical examiners to be, as practical as they possibly can be. And if something's just worded, it's not quite the way they would word it, but it's natural and it's acceptable, then I would always advise a medical examiner to accept it.
I'm just conscious that time is running on, so I'm going to let you carry on.
Thank you. There are changes to who can write the medical certificate. So as I mentioned previously, you must have attended during the last illness and seen either within 28 days or after death. Now, any doctor who attended the deceased during their lifetime can write the certificate. Doesn't mean they have to. They have to know the cause of death. So just because you saw somebody 25 years ago doesn't mean you have to write the certificate. But the idea is to open up the pool of doctors who are eligible to write the certificate if they can. There's no need to view the body after death now. It doesn't add anything. So there's no need to do that. So hopefully that is helpful and saves some time. I mentioned there's a medical examiner, MCCD, to be used in exceptional circumstances only, where the cause of death is known, but there's no attending practitioner available. And it has to go to the coroner first because there's no doctor available. But if the coroner's decided not to investigate, they'll refer it back to the medical examiner, who can then issue a medical examiner certificate of cause of death. And this avoids those uncertified deaths that I mentioned, where we all know the cause of death, but there just doesn't happen to be a doctor available. In those circumstances, the medical examiner can now write the certificate. In terms of changes to registration, used to be 5 days from the date of death. It is now 5 days from the date that the medical certificate is issued. So that's much better for the families. The clock doesn't start ticking for them until the certificate's gone to the registrar, and then they have 5 days to make their appointment to register the death. The registrar now just copies the cause of death that is provided on the certificate onto the death certificate that goes to the family. They do not question it, reject it, send it to the coroner, because the medical examiner has reviewed the cause of death and said that they think it's okay, which is why it's so important that they do that, so that unacceptable causes of death don't make it as far as the registrar anymore. If they have any queries, then they should go back to the medical examiner with them rather than going to the coroner. So it's cut off that flow of cases from the registrar to the coroner. So this may be why, if you've previously never had anybody come back to you on a cause of death, that it may come back now, because it will have to come back to the medical examiner, who may then want to talk to the attending doctor. In terms of changes to the role of the coroner, there are actually very few that affect us as doctors writing certificates. There are some minor tweaks to the notification of death regulations of 2019, but essentially the reasons for referring a case to the coroner have not changed. They're all the same: unnatural, cause of death unknown, poisons, accidents, and so on. They haven't changed. And there remains a legal requirement for any doctor who becomes aware that coroner notification is required, that they must ensure that that referral is done, whether they do it themselves or make sure somebody else does it. But there's a legal requirement to do so. The forms that coroners use have changed. So there used to be a 100A and a 100B, and I won't go into any detail on these, but if the coroner decides that they have no duty to investigate, so there's nothing about the case that triggers that requirement, they will send a form that's called CN1A to the attending doctor and the medical examiner, and then that says that the attending doctor can now write the medical certificate of cause of death. So that may be somebody who's perhaps had a fall or a fractured hip, and it's gone to the coroner, but they're happy with the circumstances, and so they can issue the certificate. If you have an uncertified death, so the cause of death is known, but there's no doctor who's qualified to write the certificate, then the coroner who decides not to investigate will issue a CN1B. That will go to the medical examiner, and then they can write a medical examiner MCCD. And the registrar is not notified of any of these. It used to be the old 100A, which meant that the coroner had investigated and they weren't going to pursue it. A copy of that would go to the registrar, so that when they got the certificate, they'd match them up. That doesn't happen anymore. The registrar knows nothing about this. If the coroner opens and then discontinues an investigation, they will issue a form called CN2, and that goes straight to the registrar. So that registers the death separately from the MCCD process. So that means the coroner's taken it on and they've done their investigation, and when they conclude it, then they'll send something to the registrar. But that's the only communication now that the registrar gets from the coroner. I mentioned for cremation forms, Form 4 is now gone. CMRs are crematorium medical referees. They're the doctors who sign off cremation form 10, which is the authorization to cremate. They are in place at the moment, but it's a transition phase, and the Ministry of Justice will review that role, and there's a possibility that it will go, or it may stay on for a little bit longer. Despite working on this for many years, there is still some work in progress. The first is a digital case management system where everything will be online, essentially. And so medical examiners will be able to put in all the information that they want to, rather than having to develop their own pro forma and store it locally. And really importantly, there will be a digital medical certificate of cause of death. So instead of the sort of old-fashioned piece of paper, you will be able to log on from anywhere with your password and fill in a certificate online. And then you'll be able to click a box, and that will go to the medical examiner to review, and then they'll tick a box and it'll go to the registrar. So hopefully that will make everything more streamlined and minimise delays. If you're not familiar with the cause of death list, I hope Cam has given you a link to it. This is a really valuable document that lists the causes of death that are and are not acceptable. So it sets out conditions that need to go to the coroner, things that need qualifying, and so on. It is being updated, but the current version is still helpful. So just to summarise, the main changes in the new system: deaths can't be scrutinised, can't be registered without scrutiny by the ME or the coroner. Any doctor who attended during the patient's lifetime can complete the medical certificate if they know the cause of death. There are those 5 changes to the medical certificate, including implants and devices, which is really important for cremation. There's a new medical examiner, MCCD, for exceptional cases, no more crem forms, and registrars no longer review the cause of death. If you want to find out more, again, Cam will share these links. The Department of Health and Social Care has a lot of information about the background to death certification reforms. NHS England and the National Medical Examiner have information about setting up services, all the contact details on there. There are contact details for every medical examiner office in the country. So if you need to find your local one, then they're on there. The Royal College of Pathologists has information about training to be a medical examiner or officer. We have a community hub, which is like a sort of Facebook forum where medical examiners and officers can share information. We host webinars and things. There's links to the Good Practice series. I'm just going to finish with some feedback from families. We were concerned initially that bereaved families would not particularly welcome getting a phone call from a total stranger when they've just been bereaved. And of course, medical examiners are doing all this within 1 to 2 days of a death. So it's really quite early on. But actually, the feedback has been overwhelmingly positive. Families really value the opportunity to talk to somebody, and they like the independence of the medical examiner. They feel reassured that somebody who wasn't involved in the care has looked at it and thinks that it was okay. So these are sort of typical of the comments about, I didn't know it existed, but I thought it was great. I was glad to have somebody to talk to. I had some concerns, but I didn't know where to go with them. It's a voice for the person who's died. It gave me closure, and it felt like my relative didn't die in vain. So I'll be quiet now and start to answer some of these questions.
Well, maybe you can take a breath. I think you've rattled through a huge amount of information there, and I think we've had so many questions. Interestingly, you must have attracted people to the career, because I've had a lot of people asking how to become a medical examiner. So I've shared some information from the Royal College of Pathologists about training to be a medical examiner. People are also asked about restrictions on that, and we can't really address the restrictions that have been put in place or the job requirements being put in place by the College of Pathologists. But anyway, it's all there for people to have a look at. Implantable devices seem to be asking lots of questions around that, causing lots of issues. And similarly, the definitions around APs seem to be causing lots of issues. And I think you've said that you're not really in a position to define it any more clearly. From a medical legal point of view, you need to be able to access notes and understand what has happened to the patient. And if you can't do that, and if you don't know why the patient has died, then it's likely to end up going to the coroner because it's an unknown cause of death. So if people aren't sure what to do, they can call us. We'll do our best to go through the guidance with them. They can talk to their ME, of course, locally for advice. Now, some other quicker questions. This one came in really early. Our local coroner has been asking us to confirm on occasion that a death is not suspicious. It's usually patients with whom there's been limited contact with the surgery, sudden collapse, no real past medical history. What makes a death not suspicious, and how should we proceed? And I've got an approach to that, but you can give us your thoughts first if you want.
Yeah, I haven't come across that before, but I mean, I think this is a completely unofficial thing. There's no guidance about it. There's no legal definition. And I would think that what they're asking is, are you aware of anything suspicious? Not really, please, can you assess this and tell me if there are any suspicious circumstances? Are you aware? And it's similar as a pathologist doing postmortems. I want to know if there's any suspicious circumstances. If somebody's found dead in bed, that's not very suspicious. But if the window was broken and the handbag's gone, then I'm a bit more suspicious. So I think I would approach that more as that, I am not aware of anything suspicious about this death, rather than confirming there's nothing.
Other people have brought up, thank you, other people have brought up the fact that different medical examiners are approaching things in different ways. Some are very pernickety, some are less pernickety, some are changing information on forms when it doesn't seem entirely necessary to do so. I guess it's individual style being brought to the role, and it's what we do different things as doctors than other doctors in the same specialities. Any comments?
No, I think that's exactly it. I'm afraid it's human nature. They all have
Yeah.
the same training. They're all told the same thing. They're all working from the same guidance. And yet people will inevitably.
And the guidance is available, isn't it? It's on the Cam has left it out there, so that's Cam's in the background doing all the tech stuff. So she's left it out there for you. It's downloadable.
I think a bit of it's also inexperience. I think when people are very new to the role, they feel they have to follow the rules very rigidly. And it's, whereas I've helped write the rules and the cause of death list and so on, I'm not so bothered. If it makes sense and it doesn't make a material difference, then I'll say, look, that's what the GP wants to write, let them write it. That's fine. I won't argue. It's not what I'd have put, it's not how I'd have phrased it, but it's no point. You've got to pick your battles, really.
Yeah, I mean, I think one of the things that somebody's asked about this particularly is that the systems being used by different medical examiners seem to be different systems. And is there a plan to harmonise between different trusts, I guess is what they're referring to?
There are many advantages of having had the non-statutory system, because it meant we could grow at the pace that we could sustain, rather than suddenly, I don't know how we'd have possibly introduced medical examiners overnight and gone from 0 to 560,000 deaths a year. But what it does mean is that there is some variation in the way in which people set up services and run them, because there was no statutory requirement to do it a particular way. With our training and our guidance and everything, and we do template job descriptions, we've got the National Medical Examiner's published guidance on how to set up and run a service. We did everything we could to standardise the way in which things were done. But there was inevitably some local variation and people found workarounds. It's unfortunate that the case management system wasn't available from the beginning, but like all NHS IT systems, they always take longer than you think. And they're not always the answer. But I think if we'd all had a national system that we used from the beginning, that would have helped standardise things. But because we all had to develop our own, we've all got a different form and we save it in a different place and ask slightly different things.
Which was a government decision rather than they decided to introduce it in a particular way back in 2019 and had been discussing it for some time. A much easier question. What is the role of medical examiners in neonatal deaths?
All deaths of live-born children count as a death that a medical examiner has to review. So we do not review stillbirths at the moment, although there are people lobbying for us and coroners to do so. But any baby that's born live has to be reviewed by a medical examiner in the same way as an adult does. Medical examiners are all trained on how to review child deaths. And there's the new guidance coming out, and obviously the Thirlwall inquiry is likely to have recommendations in relation to review of child deaths. There is already a lot of work being done, the CDOT process, and there are people both locally and regionally who are looking at child deaths in detail. Medical examiners work closely with those people, try to minimise duplication, but still give opportunities to the family to ask questions as somebody who's independent. So it's often an area that medical examiners feel slightly anxious about if they haven't previously worked with children. But we do work very closely with our paediatric colleagues to make sure that we get it right.
I'm going to do two last quick questions. I'm sorry, there have been literally over 100 questions, and they're all, a large portion are very, very good questions.
Can you send them to me?
I'll go through them at the end with Cam, not tonight, but I will go through them. So we'll look at these, absolutely.
Do send them to me.
One of the questions which did come up was, what if an ME has a particular concern about a particular, let's imagine, practice, or more likely, a surgeon like me, seeing lots of deaths coming from their operating list or from a particular department. Who do they go to, or do they do anything about that?
So they do something about it, because that's part of their job, is to spot concerns and trends and to spot them as early as possible. Yeah. So if it was an individual medical examiner, the first thing I'd encourage them to do would be to talk to their lead medical examiner, who has more of an overview of the whole service, and they could perhaps have a look at different surgeons' rates of whatever it is they're concerned about. Then the next thing to do would be probably to go to the clinical lead for surgery, and ultimately to the medical director within the trust, and to escalate it to see if there was any requirement to do anything further. You may send some of these deaths, they may go to the coroner, so the coroner will investigate. Some may go for structured judgment review within the hospital. If it's in primary care, then the first thing you would do, I think, would be to go back to the practice and just say, look, we've noticed this. Is this something you've noticed? Is there anything we can do to support? What's happening? And if necessary, you can escalate it beyond there, but we try really hard not to. I think people are often very worried that medical examiners are there sort of marking everybody's homework and are trying to get everybody in trouble and cause trouble. The vast majority of the feedback that we have, well over 90%, is positive. Feedback from families is really positive, and it's normally good news that we're telling you, not bad news.
Okay, I think we'll leave it there actually, because we're now after 8 o'clock and there are still questions coming in. I'm really sorry we couldn't do it. Thank you so much for taking the time to talk to us this evening and share your experience and your expertise. I will share the questions with you and we'll talk about how we might be able to address some of those. There have been so many of them. Thank you very much, everybody, for joining us. You can give us some feedback and get a CPD certificate, which my colleague will be sorting in the background. And the downloads that we've provided for you should fill in a lot of the gaps that we've not been able to address in what was still a very detailed presentation. There's lots more detail in those handouts and guides. Thank you very much and good night.
Thank you.
Bye-bye.